Today, let's discuss papillary thyroid carcinoma, PTC, with hobnob morphology. In the image, the upper right corner shows a hobnob boot, referencing the distinctive hobnob appearance of tumor cells seen here, cells bulging out from the basement membrane. While many pathologists might label this as the hobnob variant of PTC, that would be incorrect. Let's clarify what truly defines the hobnob variant of PTC. So, what is hobnail variant of PTC? First of all, hobnail variant of PTC is rare, accounts for less than 1% of all PTCs. It is an aggressive tumor with frequent local recurrences and distal metastasis. In addition, the tumor is resistant to radioactive iodine therapy. The prognosis is poor, with many patients die within 5 years of diagnosis. Morphologically, hobnail variant of PTC is characterized by complex branching, papillary, and micropapillary architecture. The tumor cells lining the papillae have characteristic hobnail morphology with apical snouts. We can appreciate significant nuclear atypia. In addition, the tumor cell nuclei are overcrowded and pseudostratified. Mitotic figures can be easily identified, as highlighted in red circles. Some single tumor cells, highlighted in green circles, are detached from other cells, indicating cellular discohesion. In this picture, we see hobnail morphology, increased nuclear atypia and mitotic activity, cellular discohesion, and loss of nuclear polarity, all indicating a high-grade aggressive tumor. To summarize the morphologic features of hobnail variant of PTC, the tumor forms complex papillary and micropapillary architecture. The tumor cells are often pseudostratified with loss of polarity and cellular discohesion. There is prominent cytologic atypia and increased mitotic activity. In addition, a significant subset of tumors show extrathyroidal extension. Progression to anaplastic thyroid carcinoma is common. K67 labeling index is more than 5% in the tumor cells. All tumors harbor BRAF mutation, often with secondary mutations such as TERT promoter mutation. A subset of cases have p53 mutation, which can be detected by p53 immunohistochemical stain. Clinically, hobnail variant of PTC is more commonly seen in older patients, with mean age more than 55 years. These are commonly large, invasive tumors, often more than 4 centimeters in size. Extrathyroidal extension and lymph node metastasis are common at the time of diagnosis. The tumor often pursue an aggressive clinical course with frequent distal metastasis, lack of radioactive iodine uptake, and death due to disease in a significant portion of patients. All these features are in contrast with classic variant of PTC, which is seen in younger patients, is sensitive to radioactive iodine therapy, and usually has excellent prognosis, with 10-year survival of more than 90%. Thus, accurate diagnosis of hobnail variant of PTC is essential for patient treatment and prognosis. To diagnose hobnail variant of PTC, hobnail component should comprises more than 30% of the tumor. However, as little as 10% hobnail morphology can act aggressively. Therefore, we need to report the presence of any hobnail component in our diagnosis. Returning to the initial image, here we see edematous stroma lined by a single layer of tumor cells with hobnail morphology. Is it hobnail variant of PTC? The previous picture is from a cystic mass as shown here. We can see there is a fibrous capsule at the upper right corner. Inside the capsule, we see papillary structure. Some papillae are edematous. This is a closer view of the edematous papillae. These papillae are lined by a single layer of tumor cells with hobnail morphology. The tumor cells have scant cytoplasm. No mitosis is appreciated.
If we do K67, the labeling index would be less than 5%. Here is a better picture from the article published in Histopathology in 2020. In Figure A, we see the tumor is an encapsulated tumor with cystic change. In Figure B, we can see some papillae are edematous and others are fibrotic. Figure C shows the fibrotic papillae. In Figure D, we see that the tumor cells have hobnail morphology with scant cytoplasm. No increased mitotic is appreciated.
This is classic variant of PTC with cystic degeneration and hobnail-like morphology, not the hobnail variant of PTC. PTC with hobnail-like morphology are often small tumors with a fibrous capsule. The tumor cells are small with scant cytoplasm. No significant cytologic atypia or increased mitotic activity is present. Ki67 labeling is low. No p53 mutation is detected. These hobnail-like PTC is associated with excellent prognosis, same as other classic variant of PTC. It is important that we do not mistake classic PTC with hobnail-like morphology as hobnail variant of PTC.
Here is side-by-side comparison of true hobnail variant of PTC and classic PTC with hobnail-like morphology. Hobnail variants of PTC have complex papillary architecture. The tumor cells are often overcrowded and pseudostratified. Increased mitotic activity is present. While in classic PTC with hobnail-like morphology, has simple papillae which are often edematous or fibrotic. These papillae are lined by a single layer of tumor cells with scant cytoplasm. There is no increased mitosis or significant nuclear atypia. This type of classic PTC with hobnail-like morphology is a potential diagnostic pitfall.
To wrap up, hobnail variant of PTC is a rare, aggressive subtype characterized by complex papillary or micropapillary structures, pseudostratification, loss of polarity, cellular dyscohesion, marked cytologic atypia and increased mitotic activity, high proliferative index and frequent mutations, BRAF, TERT, and P53. Classic PTC with hobnail-like morphology is a mimicker. It is characterized by simple papillary architecture with edematous or fibrotic stroma, scant cytoplasm, no significant atypia or mitotic activity, excellent prognosis. Accurate distinction between these entities is crucial for treatment planning and prognostic assessment.